All righty, so I was trying to think about controversies in acetabular fractures, and it was a little hard thing for me to think about. So what I'm going to talk a little bit about is when to do a total hip, because there's kind of a big proponent for going to that, and an extended iliofemoral. How many people have done an extended iliofemoral approach? Well, that's more than I thought. So the question is should we be doing them at all? And so that's going to be my last bit. And regardless of what we're doing, we'll be done whenever you tell me to, Joe, because I could talk forever. Interestingly, and I didn't really think about this, Poleman did this study. Most of Letronel's patients were under 60 years old, and in their database, more than 50 were greater than 60, more than 60 years old, which I thought was really interesting because I'm not sure, I wish I had asked Letronel that. You know, one of his contraindications was osteoporosis, and we're fixing a lot more people with osteoporosis. Anyway, so here's the case, and I don't know how much of you want to see. So I'm going to go through the plain x-rays and then the CT scan and see what you guys want to do, or any of the panel people. So that's your AP, that's your obturator oblique, that's your iliac oblique, and then there's your one of your cuts, your CT. I like to think that I put them all down. So this is to show you that it goes all the way down to the rami. And there's this picture, this picture. All right, there we go. Anybody need to see anything back? Everybody clear? How old? How old? Good question. 72, I think. I have that on a later slide, but I think it is 72. All righty. Anybody want to tell me what fracture that is? So this is how I look at it. I'm going to classify it. I'm going to draw it out. Then I'm going to talk about the treatment, you know, how to approach it, reduction and fixation. Anybody want to do that or not? I don't mind just going on. Here we go. That's what was done. What do you guys think? Everybody happy? It's an OIF? What do you mean it's an OIF? This is done by a good surgeon. Is it an what's the problem? It's not reduced. So the head's still medial. Interestingly enough, and I wish I had included it, I know the guy that did this, so initially, of course, that wasn't me, but it was reduced better. And okay. Go back and show it. So this is part of what he is absolutely saying, that there's been a couple studies, and I'm going to have those, where people do a primary total hip. And there's a lot of criteria that's out there. And I always hate to be but the elephant in the room is some people are not as good as others at reducing them and keeping them fixed. I can reduce this, but I can't keep it. And so this is my classic indication. You know, they talk about the number of pieces, posterior wall fractures. Those, I think, I'm not having failures. This will be a failure in my hands almost all the time. Anybody have any disagreement with that, or everybody agree with that? And so it's always important, and part of me, this first part is going to be about these impactions. But when I see something like that, I know I can't keep it that way. I mean, I've tried everything. I've brought it down perfectly, put some calcium phosphate underneath it, ran a screw on it, that kind of stuff. And did you have a question, or?
Yeah, I just,
oh.
You know, I think you've got two controversies here.
Okay, cool.
One is to fix it or replace it acutely.
Right.
And then what always comes to my mind, and you haven't given us a lot of clinical information on the patient other than his age of 72, is sometimes letting it heal and see how they do, and then go back. And then if you need a total hip, it's a much easier total hip.
Yeah. And it's good that I hadn't thought about that to some degree. I've never been one to wait on it.
You mentioned that yesterday.
I'm pretty aggressive at doing it. And it's interestingly, I have a patient case just kind of at the end of this on one where I went in with the ideas, I'm going to do your total hip, but I couldn't get the bone to stabilize. Like there was such bad bone that I woke him up and said, you're going to need a total hip. And I just not ready to do it because I got to let it heal first. And now I've got 30-year picture of him without ever his total hip.
Yeah. Yeah. So my approach to patients like this and many other patients is there's nothing so bad orthopedic surgery can't make worse. And my nurses cringe when I tell patients that. This is a bad injury in a 72-year-old guy, and it's going to be a problem for a while. But you can make it a lot worse by going in there, A, and trying to fix it and it doesn't work, or B, trying to put a total hip in and you can't get a total hip in. So again, depending on the patient, I think there's some potential benefit to letting it heal and then going in and doing a relatively simple total hip. If you need to pack some bone graft behind the cup, you use the head.
Right. And interesting, I don't quote Dana Mears a lot, but his failure rate of total hips was horrible if he didn't get, it was like 30% if he didn't get the bone stabilized. So if I go in primarily to do the total hip on this, if I couldn't get the bone to be stable, I'm not going to do my total hip because it's going to loosen. And so I felt strongly about that. This patient, one of my partners did it initially, and he knew it was a problem, and he pretty much within a couple of weeks. And she wasn't really doing that great, so I thought, perfect time, let's go ahead and do it. And you guys picked it out. So 72 years, this is what you were looking for earlier. And you talked about the femoral head, using it for bone graft, and there was already subluxation. So this is what I initially did. And what you may notice is all of those screws are still in and plates are in there. So I didn't take any of those out. I actually did a different approach. I did an anterior approach. And this is like a T-plate, and you can't really get this because we didn't mass produce it, but now we have a Stryker one that does essentially the same thing. But what I did, I used to call this the Texas T, and it kind of runs down your pillar of your gluteal, and then I ran essentially a rami plate over the top of it just to hold it, and so I stabilize the bone with that and do an anterior total hip.
Andy, what do you think about that?
About the anterior total hip? No, I'm joking.
Don't you think you could have just put a big cup in there and avoided having to put plate screws?
So I guess the short answer, no. We've had the philosophy from when we first started doing this, just what Kyle was saying. You don't have to get a perfect intra-articular reduction. You're going to ream that out and put a cup in, but you've got to have the supportive columns, well stabilized. And so from the very beginning, when we began to do acute total hips, we would fix the anterior column, the posterior column, both, whatever needed to be done, as if we were going to do a primary fixation. We just wouldn't worry about making the joint surface perfect, but we would stabilize the columns. And we often do that same thing with, you can do a lot of the fixation in these anterior column injuries through the lateral window and just get it clamped, get it reduced. But we've taken some of those big plates and bent them over and pushed against the quadrilateral surface. Now you've got the anterior intrapelvic approach and those fancy quadrilateral plates, but we've done this quite a bit. And you can do that anterior column fixation in a half hour, and a lot of patients. Just that lateral window is easy to access and fix. And you can, if you're fast, I'll sometimes get an anterior column screw down there too. I do my hips, as I was joking about it. I prefer a posterior approach for my hips. That's what I've done my whole career and I'm comfortable with. But yeah, if you're comfortable with a DAA and you do a Smith-Pete or whatever you want to do to extended Smith-Pete to do this, you can do it all through a single incision pretty well. But
I'm
like
not
the
sure.
Fixation.
I don't remember the case, to be honest, in my brain, but most of the time this rame, I would come all the way out. So I'm not sure. I just went through a much smaller anterior approach and put that in and didn't end up, because often I'll have to make a little fan and steel to get the rest of that. And, you know, I feel comfortable anterior or posterior. Generally, what I'll do is my posterior approach, if it's a very comminuted posterior wall, and then I can use that head as part of that. Most of the column type things, and I think this was an anterior column, posterior hemidiverse, and I'll go ahead and do it anteriorly. So I go where I think I need better stability.
So if you go, well, you got the crossing staples here. So you wouldn't go back to the original fixation, if you will.
Okay.
So what would have been terrible about letting it heal like this? And maybe the reason I haven't had to go anteriorly to fix the anterior column is I would have let her heal like this. You didn't even give her a chance to heal like this.
And
She's still got the staples in.
yeah, no, as I said, it was within a week or so. And so if you say, what is the problem with waiting? I can't give you a great reason why, except I know that will start hurting her and being miserable.
Well, you just said you had a patient 30 years out with a terrible looking hip.
You're going to see, I love it. I've got a little teaser for you, so you have to see what's different about that one than this one.
All right.
No, but I'll tell you. So the one that lasted 30 years, I'll blow my thing, is I had a dome impaction. And what's important, which it wasn't till that case that I figured it out, is the problem of the dome impaction is where it is. So if it's really far laterally or very far medially, those are disasters. This whole dome impaction, it was the whole thing was thing, and so it was a different. And I don't know, Steve, if you had something you were agreeing with me, or if you were, I know you do a lot of articular stuff, but where the articular thing is huge.
Well, I agree with you. That's huge. I think in general, I try to either make my decision that, like in this case, I agree you need a hip replacement at some point, and then it's do I go fix it and then do the hip initially, or like Joe is saying, do I wait, let it heal? But I'd prefer not to do an operation and then come back and redo it 2 or 3 months later, because I think to your point, they do get stiff, and the ability to get a good outcome is hard. It's harder later because because you tend to, if you want to let it heal, you really want to let it heal. You know, you want to let it go 3 months or so, in which case some people will get adduction contractures and other things.
And if I wasn't 99% sure this wasn't going to need another surgery, I would wait. But I'm 99 to 100% sure this is going to need surgery.
Yeah, occasionally you'll see a fracture pattern where there's some reasonable secondary congruency.
Right.
It's not anatomic, it's not normal, but it's still, but when you have a case like this where you've got the femoral head medialized and you've got, you know, there's a portion of the native articular surface laterally and the impacted, and it's going to be grinding away in the head, probably has already damaged the head right in there, you know, that's a bad prognosis. But when there's secondary congruency, I'll sometimes try to mobilize them and see how their pain is.
Yeah. So I think you're agreeing now with me, Joe, if I'm not correct. You can see that this head is subluxed, and so it's not going to go well with the dome of it. So that's why I would do it. But I have curious because, you know, Joe. It's not quite, but I see what you're saying due to the two-dimensional or one-dimensional picture. But anyway, I just have a question because Joe brought up something that I didn't even really think about it in this case. I did on this other case. How many people would have just waited and let this heal?
Well, that's what I was going to say. You could avoid it all.
No, that's why I'm trying to see how many people in the audience. I'm not so. Oh, there's someone that agreed, which I didn't think anybody would. Was there more than one? Oh, come on, buddy. You know, all you guys are all, you're all killing me. You're really killing me. I'm trying to show Joe how alone on an island it is, and I got 3 people that are sticking up with him.
Those 4 young ladies agree with me as well.
You 4 No, she's shaking her head. She's just no. But it's not a bad way, and I'm going to show you a case where we did that. The point is this is not going to do well. So you can wait. If you don't feel like doing the surgery till later, fine. But it's going to go bad. And to me, she's very happy with what we did. And essentially because I said, listen, this didn't work. You know, we did the best we can, but I'm going to take care of it. And I knew that I could take care of it. It's within a week of the surgery. I think she's probably more accepting, but anyway. All right.
I guess there's another controversy with
Ooh.
this case. You got a good case here, Kyle.
Yeah, I had no idea.
How about if this patient showed up at Parkland with that injury, and they put a couple of cannulated screws, one down the anterior column, one down the posterior column,
Like the one I showed yesterday.
done by Adam
Right.
himself or Charlie Reiner, would that have been, because then they talk about getting a secondary congruency. You would have never addressed the impaction, but you would have stabilized the columns with much smaller incisions.
Yeah, so it's interesting. You have the same problem that you have whether you put screws or plates on it, because you can't keep that head under the dome. Now, if you could keep it somehow, then potentially you'd be different. But to me, it's the same problem. Anybody else have any questions or comments? And it's okay if you disagree with me, because I really enjoy it. No? All right. We'll move on then. Okay, so that's what we did. So I think the thing I did with this case, and so it's not really a case, but it's something we can talk about. But she has a lot more, it's a him, he has a lot more issues with some comorbidities. And I think the key is that medial impaction of the dome can look a lot like an anterior column, anterior wall. And so you have to be able to distinguish these two. And why I put this one in there is you might look at this one and I have to look at it myself. Right here, you might say, hey, that whole thing is an impaction medially. And I hopefully will prove it with it, looking at it a little bit more, that really, oh, that's a good one too, sorry. So this impacted area where the subluxation, you see the head is subluxed. All of this has a cortical piece with it. And so this is something that can be fixed, even though it's a 71-year-old with tons of problems. It's not a dome impaction, it's an impaction of the same part of the dome, but it's with the cortical piece, so you can reduce it. And so here it is, and you can kind of see it's this piece here that I'm worried about, but it has a nice cortical piece to it. I see, yeah. And so kind of the similar type of thing. And this is a different patient, but see, there's the dome impaction. So as long as it has a cortical piece like this one, the anterior column, anterior wall, and it's not an impaction of the dome, it's more of an anterior wall elevation. We fix it like this, and she did fine with it.
So go back to your arterial oblique.
The initial one?
Pre-op, yeah. So what you're talking about.
Sorry.
Yeah, one more. Thank you. So what you're saying here is this piece here.
Is all, yeah.
So it's not an impaction of just the articular surface, it's actually a separate piece.
Right. And that's a huge distinction to make in terms of potentially doing a total hip versus not.
So you think you got a better chance of getting this reduced and stabilized?
And it will stay reduced.
Yeah.
It's got me thinking when Joe said that impaction is very difficult to deal with when you're doing fixation. It's very easy to deal with a total hip. You don't have to
Right.
even worry about it, really. You put a little frontal head graft in there and you're done with it. So if you tried to do a total hip in that case, you got a whole segment of acetabulum that's cortical bone and everything, that you got to be prepared to that's got to be
Right.
fixed either way.
You know, unfortunately, as you've been talking, Andy, I quote, and I think Templeman was the lead author, so it's his name or whatever instead of yours, but you were on the dang paper I'm going to criticize, so I appreciate it. All righty. Any questions on that? That's an important distinction, hopefully. This is what I was going to try to say. If you look at this is not Steve's work, but he did some great stuff on articular surface. Wait, I'm going to just brag about Steve a little bit. So what he did, which I think is so fascinating that people didn't, he took a cadaver, the Fujifilm stuff, and he broke the acetabulum, and then he put it back together anatomically, and there was still a loss of, basically, like you can never get it perfect. So when I always say get it perfect, you can't do it. Steve, do you want to add to my summary of your research?
I think that the simplest way to put it, as I understand it, is that in the native hip, when you load the native hip, what actually happens mechanically is the acetabulum bends around the femoral head.
Right.
And when you break it, it loses that ability to deform, so the contact stresses are different in the joint.
When you break it, plate it, and let it heal.
Then to Joe's point, and that's hard to simulate. We tried to do it with some Norian stuff, and it suggested if you put grout in there, it's a little better, which would suggest if it heals, it might come back to normal. Yeah.
So we don't know, but to me, I thought it was fascinating. He perfectly reduced it, and it still wasn't the same. Right. And so this basically shows the two areas that I told you. If those areas have impaction, this is the critical area for your acetabulum, and it's very hard to hold that reduction. And I've seen it on both sides and have cases on it. So this is the title of this little section is I got to know his limitations, and it's really looking at impactions. And not often, so I fixed this guy's right side, unfortunately, because of femoral neck, that's my hip. Unfortunately, got in another horrible car accident. So we're focused on this side a little bit. And to some degree, it's a both column fracture to some degree, but it has more of an anterior column, posterior heavy diverse with a large posterior wall. So this was the fixation initially, done at a very good trauma center, not going to pick on the guy, very good surgeon, well known, everybody would know who he was. And they did this, and he decided that he could do better. And so he went back and put all these stupid little plates, which does absolutely no good at all. Did a trochanteric osteotomy as well. And the good thing is he eventually got back to me at this point. And you know that's not going to do well. And so it didn't do well. So I put an allograft in, put a total hip in, and did it. And no, that's not the one. This is another one, a posterior column, posterior wall. And I guess I wanted, before I leave this one, is my point is I love people that get CTs afterwards. I never did that, and I wish that I'd done more because I think you can learn a lot. But it's this problem right here. This piece is impacted, and that wasn't going to do good unless you got that. I don't know if you could have gotten reduced. He's a younger person, so maybe you could have. Anyway, but to make the story worse, this is the same guy, but a different problem. And actually, he came to me and he said, hey, I don't understand, this case. Can you help me? Anytime you see 3 plates on the posterior column, you know it's a bad thing. And he said, what was the problem? And I said, well, you never reduced the impacted piece. And it's just like a tibial plateau. You see this kind of density there. That's an impaction. And if you don't address it, and this is a younger guy, you maybe could have done that. And I said, well, it's this impaction. You never reduced it. And he goes, no, that's not it. And I'm like, okay, never mind. And so he asked for my help, and then he didn't. But you can see that, this one was harder to see, but there is an impaction there that's just not reduced. Unfortunately, the patient eventually got to me, more probably not want to. I have never seen a case like this before, so I'm showing you guys. The sciatic nerve is right in the center of all that. And so it's a disaster, but we ended up kind of teasing out the sciatic nerve and then doing a total hip. So here's your article. Do you want to comment on anything? And my point is I think it's awesome, these articles, because in his or their group's hand, a total hip did better in these patients than otherwise. You want to summarize it since it's your paper? I don't want to go
Well,
over.
this is specifically to posterior wall fractures.
That's just to remind you, yeah.
But what was interesting was we had the idea that we were doing these acute total hips on much older patients, and we had a fellow who was interested in this and began to look, and we found that we actually had a large number of patients with posterior wall fractures that were getting acute total hips. And you know, the data does show that if you have a posterior wall that's comminuted with marginal impaction and femoral head lesions, the prognosis is poor. And we found, and I think others have seen the same thing, that they usually deteriorate within a year. You know, so could you get 5 years, 10 years? You know, I remember having a lot of talks about, you know, if you could tell a patient we'll get X amount of years, you know, before your second surgery, when is it worthwhile to try the fixation? But this is really these injuries that you've kind of defined there: marginal impaction, femoral head damage, and comminution. We're trying to pick those patients, and just like we were routinely doing acute or immediate total hips on patients in the 50-year plus age range, which I'm now well beyond, you know, with a displaced femoral neck fracture. So if they've got a similar lesion on the acetabular side, why not just do an acute total hip? It's fairly easy to do total hip on a posterior wall fracture. Yeah. So that's what this series was theoretically looking at.
And I guess my disagreement with him, so I wanted him to say everything first and then pick on him. No, I'm just kidding. I've never done a total hip on a posterior wall fracture primarily. Now, if there is that dome impaction I've talked about associated with a posterior wall, yes, then I've done those. And so the impaction in a posterior wall, and he did bring up a good point, I can't solve femoral head impactions either. So if there's a femoral head damage, that patient's not going to do well, and so that's going on. But the simple posterior wall, I'm not ready to do a total hip on those people.
Yeah, but I think Andy brings up a good analogy. You do the same thing if it was on the femoral side. I've had patients with osteoarthritic hips, maybe not end stage, but osteoarthritic hips who come in with posterior wall fractures. And rather than putting them through operations, fixing the posterior wall, letting it deteriorate and do a total hip, I've gone ahead and done a total hip and they feel great. And nowadays they're lasting. I got a patient now I saw 27 years after a total hip that was put in 1999. So our better hips, our newer hips are lasting even longer. So even though these patients were 45 to 65 years old, it's still a reasonable option.
Yeah, no, and I think it's always a reasonable option, and I don't want to say that Andy's group should keep doing that. My point is I have a guy in my total hip thing on acetabular that was on his way to his orthopedic surgeon to get scheduled for a total hip, and he got in a car accident, and we did the total hip and fixed the fracture as well.
Yeah, I remember a patient we had at Tampa General showed up with a posterior wall acetabular fracture, a degenerative hip, who had already donated 2 units of blood. Back when we used to donate before the total hip.
Right. And his article and Veris both came out with similar type of things in terms of trying to maybe do it. And I think it's reasonable to do a total hip. And just like Joe says, I don't think I'm that smart, and I'm not trying to sell Biomet because I'm not getting any money, but I put taper locks in, I've got them out 40 years, you know, and they're still doing good. And I think I guessed right because it's a wonderful implant and it's got the best 30-year results, but I caught a lot of grief for not keeping up with times and, you know, changing what I'm doing.
Well, let's not give those young surgeons in the far side of the room the wrong impression.
Yes.
We should be fixing the majority of these acetabular fractures and not just throwing in the towel and doing total hips.
Yeah, and that will be made in just a slide later. Am I out of time, Joe?
No, you can keep going.
Okay.
We got a ton of time.
Well, I want to be done in 7 minutes. I got to be done at 3. So this is the gentleman that I told you about. And it might be hard to see because you're like, is it even broken? But here's your ilioischial line here. And what you can see is that the entire dome is impacted there. And I know you don't believe me from that one, but.
Shrek doesn't.
Is this a little better? Yeah, hopefully you guys can see this. So this whole piece is impacted. This guy, he also had a shoulder glenoid fracture at the same accident. So I took him to surgery. This is in 2000. And you see, you know, when you start seeing cerclage wires here and trying to I mean, I was trying everything. And I fixed it, and the bone was still moving. I'd push it, and I'm like, I can't do a total hip in this guy. And so I woke him up, and I said, I didn't fix it that great, and I did everything I can, but your bone is too bad. And he goes, that's okay. Yeah, we can do the total hip later. Very nice guy. So here's his 10-year follow-up. Here's his 20-year follow-up. I thought I had maybe even, he comes every 2 years still. But anyway, and this is my the area that's affected by your impaction is critical. So this, most of his dome, and that's what I've taken from this case, is that, where it is important. So this was the summary. You can certainly consider it when there's femoral head, the dome impaction, medial or lateral, pre-existing osteoarthritis, as Joe said. I don't know about osteoporosis. I think ORIF is still the gold standard, even in the elderly. And interestingly, a primary total hip with an acetabular fracture still has more failures than a total hip without the thing. And I'm going to go quickly over this. This was I love this because should we be doing an extended iliofemoral? And it's a big surgery, so if you haven't seen it, and I was surprised at how many people had seen it, but the residents used to call it a shark bite. You basically take the whole buttocks off of the back side of the thing. And I have fellows that have done like 40 of them, and they won't do them when they go out to practice. So that's how bad it is. I always give radiation to them, so I've never had any HO. And at some point, and maybe someone was involved with this, but CORE asked me to look up my extended iliofemorals. And I looked them up and sent them in, and they said, well, we're not going to publish it. And I'm like, okay, fine. He had 20-year follow-up. It's my personal, I'm a sports medicine doctor too. So that horse landed on her, and she was a professional. She had a transtectal transverse posterior wall, and Letronel says that you need to do an extended iliofemoral for that injury. And so here's the fracture. It's clearly an operative indication. I've gotten permission from her, by the way, to show her ass all over the country. And T fractures, to me, are like a step up from the transverse. It's a transverse with the separation of the two columns. But again, if there's, a lot of times I'll try to do those through a coker, but if there's more than a week delay, and I think Letronel is the one that said that, or his might have been a little longer, but after a week, I cannot reduce the anterior column from the posterior approach with this. I'm not going to go much into that. We're going to skip. So the story was actually funny, so I'm going to tell the story if I have time. Yeah, 4 minutes left. So I'm with my son at Boy Scout camp, and I get a call, and it's actually the husband of her, and he says, hey, I got this thing, I need your help. And I said, okay. And I'm trying to remember. I was trying to send him to LA, to Joel, or Krieger on the East Coast. And she was at Wyoming at the time. And they call, and so I go back. And every time I had to go to the scout station because there's no cell service, I'd get called back, and they're like, he goes, I heard you're the man to do it. And I'm like, I'm at scout camp. And he goes, well, I've got a private plane, Clint Black's private plane ruined me for flying the rest of my life because I got there, laid down, took a nap. Oh, wait, they had a chef that made me breakfast before I slept. Slept the whole way, woke up, went and did the case. They flew me back. And I said, well, when are you guys leaving? When you get here, Doc. And I was like, it was awesome. But anyway, that's the funny part of the story. He had said, I want you to do it. And I said, well, I'm not. I'm at Boy Scout camp. And he said, well, what if this is your wife? And I said, if it was my wife, right, I would go home and do it. But she's not my wife. And he said, well, ask your son if it's okay. So I went and asked my son, and he said, Dad, that's cool. Go do it. So I was only gone a day, but anyway, that's the funny part of the story. So that's what we did. We fixed her, and it was through an extended iliofemoral. A year and a half later, she became the world champion, won the pickup truck and everything at the National Rodeo. And unfortunately, that's me, the ugly guy with the big hat. So So this was my results when looking them up, and it's always ruins your good results when you have to look up your own results. And I was shocked that I had a 17% infection rate. And every one of those were ones that got sent to me already had a coker, and I redid it through an extended. It's not that I don't do that, but I now can say, hey, about 1 in 5 of these gets infected. And it was only like a 10% chance of getting a total hip. So I think for the most part, they did pretty well. And that's it. Thank you.
Hey, Kyle, any,
Really think that case you showed us that you could do that with a trochanteric clip through a coker?
I can't do that through that. Yeah. So it's funny that having your clamp on both anterior and posterior, I think, is critical for reducing those transtectal because it has to be perfect.
Right. No, it has. I mean, but the point, to me, the point was always that you had to see in the joint. That was why you were doing the extended iliofemoral in the old days.
Yeah.
And I think the majority of those now you can do with a trochanteric osteotomy and
If you can do that, then you're a much better surgeon than me, for one thing. But I need the young Bluth clamp on the anterior and posterior. Yes, the extended allows me to look in the joint, but Letournelle said that it was the reduction of the joint that was the critical.
Yeah.
And I can't do it with the slide, and I do a lot of them. But anyway. Any other questions about that? All right.